Sir, I need you to calm down and stop yelling. Dr. Rachel Morrison didn't look up from her tablet as she spoke. Her voice carried the practiced patience of an ER physician who'd heard every excuse, seen every manipulation, dealt with every drug seeker who walked through those automatic doors. The man in seat 7 wasn't yelling. He was barely speaking above a whisper, one hand pressed against his chest, the other gripping the plastic armrest of the waiting room chair, with enough force to turn his knuckles pale. Please, he said, his voice tight. The pain. It's getting worse. Left arm, jaw. I think I'm having a heart attack. Rachel finished for him, her tone making it clear she'd heard this particular story before. Sir, you're 52 years old. You walked in here on your own. Your vitals at triage were borderline, and quite frankly, your behavior is more consistent with drug seeking than cardiac emergency. Have you ever been so certain about someone that you stopped listening? Have you ever let your assumptions override your training, your oath, your humanity? What happens next will haunt this hospital forever. The Johns Hopkins Emergency Department hummed with its usual Tuesday afternoon chaos. Trauma bays processing car accidents, nurses triaging flu cases, medical students fumbling with IV lines under attending supervision. The controlled chaos of American healthcare operating exactly as designed. In seat 7 of the waiting area, Dr. Isaiah Carter sat very still, trying to control his breathing. Each inhale felt like broken glass scraping through his chest. The pain radiated from his sternum down his left arm, in waves that made his vision blur at the edges. He knew what this was. He diagnosed it 1,000 times. Stemmelabor, stain elevation, myocardial infarction, the widowmaker, time sensitive, door to balloon, time critical. Every minute of delay increased mortality risk by 7. He'd literally written chapters in the textbook about this. Please, he said again, forcing the words through the tightness in his throat. I need you to run an EKG, troponin levels. I'm a physician. I know what. Of course you are. Rachel's smile didn't reach her eyes. She'd learned to recognize the patterns. Drug seekers always claimed special knowledge, always tried to use medical terminology to sound credible. This one was better than most. She'd give him that. The expensive suit was a nice touch. The watch probably cost more than her monthly rent, probably stolen. Your triage vitals were BP 142/88, heart rate 94, oxygen saturation 97%, Rachel recited from her tablet. None of those numbers scream cardiac emergency. What they do scream is someone who knows just enough to fake symptoms convincingly. Isaiah's right hand trembled as he reached for his wallet. The movement sent fresh waves of pain through his chest. My ID. If you just look at my... Sir, I don't need to see your ID. What I need is for you to wait your turn like everyone else. We have actual emergencies to handle. But Isaiah Carter wasn't everyone else. He was the reason this hospital existed in its current form. His research grants had built the cardiac wing. His reputation had attracted the world's best cardiac surgeons. His name was carved in marble in the main lobby. But Rachel Morrison had never looked at the main lobby. She'd entered through the staff entrance every day for 3 years, past the service elevators, through the fluorescent-lit corridors, where the marble gave way to linoleum, and the donors' names gave way to equipment storage. She'd never seen the portrait. Nurse Collins. Rachel called to the triage station. Can we get this gentleman some water and maybe a Xanax? I think he's having an anxiety attack. Marcus Collins looked up from his computer screen, glanced at the patient in seat 7, and something flickered across his face. Recognition? Concern? It passed too quickly to read. Dr. Morrison, I think maybe we should
prioritize the pediatric patient in Bay 3 with actual respiratory distress, Rachel interrupted. Not someone who's watched too much Grey's Anatomy.
Marcus hesitated, then nodded slowly. He'd learned not to contradict attending physicians. That's how you lost shifts. That's how you lost recommendations. That's how you ended up working overnight at community clinics in bad neighborhoods. So he said nothing. And Isaiah Carter's myocardial tissue continued to die, cell by cell, minute by minute. The thing about medical racism is that it doesn't announce itself. It doesn't wear a hood or burn a cross. It wears scrubs and a stethoscope. It speaks in clinical terms. It hides behind protocols and triage algorithms and diagnostic criteria. It sounds like your pain level can't really be that high. It sounds like, let's try Tylenol first before we move to opioids. It sounds like, I think you're exaggerating your symptoms. And sometimes, it sounds like Dr. Rachel Morrison telling a world-renowned cardiologist that he's faking a heart attack. The statistics are brutal and undeniable. Black patients in American emergency rooms wait 30% longer for pain medication than white patients with identical conditions. Black heart attack patients experience treatment delays 19% more often than white patients. When black patients report pain scores of 10-10, they're believed 40% less often than white patients reporting the same scores. Isaiah knew these numbers. He'd presented them at medical conferences. He'd published papers on implicit bias in emergency medicine. He'd trained thousands of medical students on recognizing their own prejudices, but he'd never imagined he'd experience them firsthand, in his own hospital, from a doctor he'd personally approved for hiring 3 years ago. Dr. Morrison. Isaiah tried one more time, his voice barely audible now. I'm not drug-seeking. I'm Isaiah Carter. I'm the person making a scene in my ER. Rachel cut him off. Look, I get it. You're uncomfortable. You want immediate attention, but that's not how this works. We treat based on acuity, not on how loud someone complains. She turned away, already moving toward the next patient. Isaiah felt his left arm go completely numb. 12 minutes had elapsed since Isaiah walked through those automatic doors. In that time, his left anterior descending artery had been 90% occluded. His cardiac enzymes were spiking. His EKG, if anyone had bothered to run one, would have shown the distinctive ST elevation pattern that gave STEMI its name. His body was doing exactly what he'd taught medical students to watch for: the textbook presentation of a massive heart attack. But Dr. Rachel Morrison was watching for something else entirely. She was watching for the patterns she'd learned to recognize. The manipulative patient, the drug seeker, the person who'd learned to game the system, and she was very good at recognizing those patterns. She just didn't realize her pattern recognition had a fatal flaw. Research from the University of Virginia School of Medicine revealed a disturbing truth. Approximately 40% of medical students and residents held false beliefs about biological differences between black and white patients. They believed black people had thicker skin. They believed black people had higher pain tolerances. They believed black people were more likely to fake symptoms. These weren't conscious beliefs. Most would have been horrified to hear them stated out loud. But implicit bias doesn't require conscious awareness. It operates in the gap between what we believe about ourselves and what our actions reveal. Rachel Morrison would have sworn under oath that she treated all patients equally. She would have passed any implicit bias test the hospital required. She genuinely believed she was a good doctor who made decisions based on clinical evidence, not race. But the man in seat 7 was dying, and she was watching him die while congratulating herself on not falling for his manipulation. Somebody help. The voice came from the waiting room entrance. A young woman in scrubs, someone from radiology, was pointing at seat 7. That man is having a seizure. Rachel spun around. Isaiah Carter was no longer sitting upright. His body had slumped sideways in the chair, his face gray, his lips tinged with blue. His eyes had rolled back, and his right hand was clutching at his chest in one final desperate attempt to signal what was happening inside. Code Blue. Waiting room. Rachel shouted, finally running toward him. The response was immediate. The Code Blue team materialized from 3 different directions: crash cart, defibrill, aider, oxygen. The choreographed dance of emergency medicine kicked into high gear. Nurse Marcus Collins reached Isaiah first. His fingers found the carotid pulse weak, thready, irregular, pulse present but barely, respirations shallow. Someone get me an EKG. They lifted Isaiah onto a gurney. The movement jostled his suit jacket open, revealing the lanyard he always wore: hospital ID, security access, executive privileges. Marcus saw it first. His face went white. Oh my God. What? Rachel was already cutting away Isaiah's shirt, preparing for defibrillator pad placement. Dr. Morrison, you need to see this. Not now, Collins. We have a... Now. Marcus's voice cracked with urgency he'd never shown before. He held up the hospital ID, hands shaking. Look at this. Look at this. Rachel glanced at the ID card, irritation flashing across her face. Then she actually read it. Johns Hopkins Hospital. Dr. Isaiah Carter, Dean of Medicine. Department of Cardiology. The world stopped. Not literally, of course. The code blue continued. Hands moved. Medications were administered. The EKG machine started recording the catastrophic electrical chaos of Isaiah's failing heart. But for Rachel Morrison, time fractured into before and after. Before she knew, after she knew. 18 minutes, someone said. Marcus Collins, his voice hollow. He's been here 18 minutes. The EKG printout told the story in cold, clinical detail. Massive STEMI, probably occluding the left main coronary artery. The kind of heart attack that killed 40% of patients, even with immediate treatment. The kind that required a catheterization lab within 60 minutes to have any chance of full recovery. They'd wasted 18 minutes. Get him to the cath lab now, Rachel heard herself saying. Her voice sounded distant, disconnected from her body. Page Cardiology. Tell them it's Dr. Carter. Tell them. They know, another voice said. Dr. Jennifer Wu, the cardiology fellow, had appeared at the foot of the gurney. Her face was grim. The whole department knows. Someone recognized him from the cameras. They're prepping the lab now. As they rushed the gurney toward the elevators, Rachel saw it for the first time. The portrait, hanging in the main lobby, impossible to miss if you entered through the front doors. 6 feet tall, oil on canvas, capturing Isaiah Carter in his academic regalia. The nameplate below read, Dr. Isaiah Carter, Dean of Medicine, pioneer in cardiac surgery, established the Carter Protocol for equitable pain assessment. The Carter Protocol. The bias prevention training that every physician at Johns Hopkins was required to complete annually, the systematic approach to ensuring that patient race didn't affect treatment decisions. Isaiah had created it after analyzing 10 years of ER data and finding exactly what happened to him today. Systematic delays in treatment for Black patients reporting chest pain. He'd created the solution. He'd trained the doctors. He'd transformed the system. And it still hadn't protected him when he needed it most. The catheterization lab was a study in controlled chaos. Dr. Sarah Chen, Isaiah's protege and the director of interventional cardiology, took control the moment Isaiah's gurney burst through the doors. Window of opportunity is closing fast, she said, her voice steady despite the tears streaming down her face. His EKG shows complete occlusion of the left main. We're talking minutes before irreversible damage. She looked directly at Rachel Morrison, who stood frozen in the doorway. Who was the attending in the ER? Rachel tried to speak. Nothing came out. It was Dr. Morrison, Marcus Collins said quietly. He'd followed the gurney up, unable to leave, unable to unsee what he'd witnessed. He came in complaining of chest pain. She thought he was drug-seeking. The silence in the cath lab was deafening. How long was he in the waiting room? Dr. Chen asked, her voice dangerously quiet. 18 minutes. Dr. Chen's hands never stopped moving. She was threading a catheter through Isaiah's femoral artery, racing against time and mortality. But her voice, when she spoke again, could have frozen nitrogen. The Carter Protocol guidelines specify immediate EKG for any patient presenting with chest pain. Gender, race, age, appearance, irrelevant. Every patient, every time, no exceptions. She looked up at Rachel. He wrote those guidelines specifically to prevent what you just did, and you did it anyway. The arterial blockage was worse than Dr. Chen had feared. The left main coronary artery, the widowmaker, was 95% occluded. 18 minutes of delay had allowed the clot to stabilize, embed itself, begin the cascade of tissue death that would either kill Isaiah or leave him permanently disabled. I need more time, Dr. Chen said. though everyone in the lab knew time was the one thing they didn't have. The procedure took 47 minutes. 47 minutes of threading catheters through arteries, placing stents, watching monitors for signs that Isaiah's heart was giving up entirely. Twice, his rhythm deteriorated into ventricular fibrillation. Twice, they shocked him back. When it was over, Isaiah Carter was alive. Barely. Dr. Chen stripped off her gloves and walked directly to where Rachel Morrison still stood, frozen in the doorway like a statue of her own failure. "He'll survive," Dr. Chen said, "but he's lost approximately 30% of his left ventricular function. His ejection fraction is 35%. Normal is 55–60%. That damage is permanent." She let those words hang in the air. Dr. Isaiah Carter, one of the finest cardiac surgeons this hospital has ever produced, will never operate again because you couldn't see past his skin color long enough to follow basic protocols. Rachel's voice, when she finally found it, was barely a whisper. I thought." "You thought what, Dr. Morrison? That a well-dressed black man complaining of chest pain must be lying? That someone who could afford that suit and that watch must have stolen them? That black patients exaggerate their symptoms?" Dr. Chen stepped closer. "Here's what I think you thought. You thought exactly what the data predicted you'd think. You exhibited the exact implicit bias that Dr. Carter spent his career trying to eliminate. And now he's paying the price for your education." But this wasn't the end of Rachel Morrison's education. It was only the beginning. Because 24 hours later, when Isaiah Carter regained consciousness in the cardiac ICU, his first words weren't about himself. They were about her. The thing about Isaiah Carter that most people didn't understand was this. He didn't become Dean of Medicine by accident. He didn't transform Johns Hopkins into a model for equitable healthcare through luck. He didn't create the Carter Protocol because he was naive about human nature. He did it because he understood, with painful clarity, exactly how the system worked and how it failed people who looked like him. When he opened his eyes 31 hours after his heart attack, the first person he saw was Dr. Rachel Morrison. She'd been sitting in the chair beside his bed for 6 hours, not sleeping, not reading, just sitting, staring at her hands, wrestling with the weight of what she'd done. "Dr. Morrison." Isaiah's voice was hoarse from the breathing tube they'd removed 3 hours earlier. "Thank you for staying." Rachel's head snapped up. "Thank you? After everything she'd—" "We need to talk," Isaiah continued, each word clearly painful. "Not about me, about you, and about every patient you'll see for the rest of your career. This is where most people expect the revenge story. The firing, the public humiliation, the destroyed career, the dramatic justice that feels satisfying in the moment, but changes nothing about the system." Isaiah Carter had a different vision. Over the next 3 days, as he recovered in the ICU, he did something that would have seemed impossible to anyone who didn't know him. He began training Dr. Rachel Morrison, not formally, not officially, but in the quiet hours between rounds, when she would come to check his vitals because she couldn't stop coming, couldn't stop facing what she'd done. He would ask her questions. "Tell me about the first time you made a split-second judgment about a patient based on their appearance. Walk me through your thought process when I walked into the ER. What specific things made you dismiss my symptoms? When you look at me now, knowing who I am, do you see me differently than you did in the waiting room? What changed?" These weren't accusations. They were the questions of a teacher who recognized a teachable moment, because Isaiah understood something that most people miss. Dr. Rachel Morrison wasn't a bad doctor. She was a product of a system that had taught her, through 10,000 invisible lessons, to see black patients as threats rather than people in need. She'd internalized those lessons so completely that she didn't even know they were there, until they nearly killed someone. On the 4th day, Isaiah was strong enough to sit up. His ejection fraction had stabilized at 35%, far from normal, but enough to sustain life. He would never perform surgery again. The precise hand control required for cardiac procedures was beyond what his damaged heart could support. He'd accepted this with the quiet grace of someone who understood that outcomes don't always reflect effort or justice or fairness. Sometimes they just are. "I need to show you something," he said to Rachel, who'd become a fixture in his room. Sitting, listening, learning in real time how her implicit biases had materialized into life-threatening harm. He opened his tablet, the one his wife had brought from his office, and pulled up a file he'd been compiling for 3 years. This is the ER treatment data from Johns Hopkins. All patients presenting with chest pain over a 36-month period, broken down by race, gender, age, and treatment timeline. Rachel leaned forward, her medical training automatically analyzing the charts and graphs. The average wait time for white patients presenting with chest pain, 6.2 minutes from triage to EKG. He swiped to the next chart. The average wait time for black patients with identical presentations, 18.7 minutes. Rachel's face went white. But here's what's interesting, Isaiah continued, his voice still weak, but his analysis sharp as ever. When we implemented the Carter protocol, mandatory EKGs within 10 minutes regardless of race, age, or appearance, those numbers converged. White patients, 5.8 minutes. Black patients, 6.1 minutes. He looked directly at Rachel. The protocol works. The data proves it works. But only when people actually follow it. The implications hung in the air like smoke. I didn't follow it, Rachel said. It wasn't a question. You didn't follow it. And I nearly died. But Rachel and I need you to hear this. You're not unique. You're not unusually biased. You're not a bad person. You're a statistically predictable outcome of a system that trains people to see patients like me as threats. He coughed. A painful reminder of how close he'd come to not having this conversation. The question isn't whether you have implicit bias. Everyone does. The question is, what are you going to do about it? What Rachel Morrison did about it changed American medicine. Not immediately, not dramatically, but through the quiet, persistent work of someone who'd been given a second chance and refused to waste it. She became the poster child for the Carter Protocol 2.0, the expanded version that Isaiah designed during his recovery. Not just EKG requirements, but a comprehensive system for identifying and correcting implicit bias in real time. Every patient interaction recorded, every treatment decision analyzed, every delay documented and reviewed, not for punishment, but for learning. Rachel volunteered to be the first physician to have her ER shifts monitored under the new protocol. Every decision she made, every patient she saw, every split-second judgment, all captured, analyzed, and used to train other physicians. This is Dr. Morrison's patient interaction from 2:37 p.m. The training videos would show. Note how she initially assesses the patient's pain level. Now watch her catch herself making an assumption based on the patient's appearance. See her pause, run through the protocol checklist, and adjust her approach. The training wasn't about shaming. It was about recognition, about giving physicians the tools to catch their biases before those biases caught their patients. Within 18 months, the Carter Protocol 2.0 was being implemented in 67 hospitals across 12 states. Within 3 years, it was taught in 89% of American medical schools. And the data told a story that made Isaiah Carter smile from his new position as senior advisor on healthcare equity. He could no longer serve as dean of medicine. The cardiac damage made the role's physical demands impossible. Emergency room treatment disparities were declining, not eliminated. Systematic racism doesn't disappear that quickly, but measurably, documentably declining. Black patients with chest pain were being taken seriously, being treated immediately, surviving at rates that had been impossible 5 years earlier, and Dr. Rachel Morrison was leading the charge. The Carter legacy. 3 years after that Tuesday afternoon in the ER, Isaiah Carter stood at the podium of the American Medical Association's annual conference. His pace was slower now, his speeches shorter. Cardiac capacity limited his endurance, but his message was sharper than ever. I nearly died in my own hospital, he told an audience of 3,000 physicians. Not because of medical error, not because of equipment failure, not because of lack of knowledge. I nearly died because a well-trained, competent physician couldn't see past my skin color long enough to follow basic protocols. He paused, letting that sink in. Dr. Rachel Morrison saved my life. Not in the ER. She nearly killed me there. She saved my life by having the courage to face what she'd done, learn from it, and dedicate herself to making sure it never happened again. In the audience, Rachel Morrison sat with tears streaming down her face. Isaiah had insisted she attend, had insisted she be recognized, not for her failure, but for her transformation. The Carter Protocol isn't about punishing bias, Isaiah continued. It's about recognizing that we're all products of a system that teaches us to see certain patients as more credible, more deserving, more human than others. The protocol doesn't eliminate those teachings, it interrupts them. It gives us a chance to override our conditioning with our training. He clicked to his final slide. It showed 2 timelines. Before Carter Protocol 2.0. Average ER wait for Black patients with chest pain. Survival rate 78.2%. After Carter Protocol 2.0. Average AR wait for Black patients with chest pain, 6.4 minutes. Survival rate, 91.7%. That's 13.5% more Black patients surviving cardiac emergencies, Isaiah said. That's thousands of lives saved annually. That's fathers coming home to their children. That's mothers living to see their grandchildren. That's the power of acknowledging our biases and building systems that don't depend on us being perfect. The standing ovation lasted 4 minutes. 6 months later, the letter arrived at Johns Hopkins on a Tuesday morning. Coincidentally, exactly 4 years after Isaiah's heart attack. It was from the family of Marcus Williams, a 54-year-old Black man who'd presented to a community hospital in rural Georgia with chest pain. Under the old system, he would have waited, would have been dismissed, would have died. But the ER physician had been trained in the Carter Protocol, had immediately run an EKG, had seen the STEMI pattern, had activated the cath lab within 11 minutes. Marcus Williams survived with minimal cardiac damage. His ejection fraction was 58%, nearly normal. Dr. Carter, the letter read, my father is alive because you nearly died, because you turned your trauma into training, because you refused to let your suffering be meaningless. Our family owes you a debt we can never repay, but we can pay it forward. My daughter starts medical school next fall. She wants to specialize in emergency medicine. She wants to be part of the generation that makes the Carter Protocol unnecessary, because bias will be so thoroughly eliminated from medical training that we won't need protocols to interrupt it. Isaiah read the letter 3 times, then handed it to Rachel Morrison, who now directed the Johns Hopkins Center for Equitable Emergency Medicine. This, he said quietly, is why we do this work. Rachel nodded, unable to speak, because she understood now what Isaiah had understood all along. Justice isn't about punishment. It's about transformation. It's about taking the worst moments of human failure and transmuting them into systematic change. It's about the quiet power of education, overcoming the loud legacy of bias,